I'm very, very thankful for this opportunity to talk to my colleagues about insomnia evaluation and management, not to waste too much time. So the first thing I want to talk to everybody about is understanding insomnia. I think that before you can treat a condition, you have to make sure you get the diagnosis right. That's the most important probably part of things. And in order to get the diagnosis right, you have to understand insomnia symptoms and understand insomnia. This should probably say insomnia disorder, but that's what we're going to talk about first. And so in the past 6 months or so, I think the International Classification for Sleep Disorders gave an update called the 3TR for the diagnostic criteria of various sleep disorders. And not much has changed between 3 and 3TR. There are still 3 main categories of looking at insomnia and placing an insomnia disorder diagnosis according to the diagnostic manual. So there's something called chronic insomnia, there's something called short-term insomnia, and there's something called other insomnia. So chronic insomnia and short-term insomnia are essentially very similar in terms of how they present, but the differentiating factor is the fact that chronic insomnia goes on for more than 3 months, and short-term insomnia goes on for less than 3 months. There's still difficulty with initiating or maintaining sleep. There's difficulty waking up. There's, despite normal sleep opportunity, and it's not due to another condition. And that's a very important aspect of being able to place a proper diagnosis, because a lot of other conditions can cause insomnia type symptoms, and it may not be a chronic insomnia disorder. And you can have chronic insomnia and another sleep disorder or another condition at the same time. So the difference between older diagnostic criteria manuals and this newer one, also, as well as the DSM-5, is the fact that you can still have 2 diagnoses at the same time. It's not insomnia secondary to anymore that we typically write. So that's actually the history of arriving at these kind of, I guess, characterizations. So you have DSM-4 and ICSD-2. DSM-4, splits insomnia into primary insomnia and secondary insomnia. DSM-5 breaks it down in terms of, again, time frame of symptoms underneath the umbrella category of sleep-wake disorders. And you got insomnia episodic, persistent, or recurrent. So it's kind of similar between ICSD-3 and DSM-5. And then ICSD-2 also had a breakdown of insomnia in terms of primary and potentially secondary conditions. And you had psychophysiological, idiopathic, paradoxical, inadequate sleep hygiene, which it's actually not a form of insomnia. So, insufficient sleep syndrome is a big part of that. And then behavioral insomnia of childhood. So, all right, let's just go on. Insomnia can occur with other sleep disorders. And a lot of people who have short-term insomnia, they can go on to have something called chronic insomnia. In fact, according to this study down here from 2020, 20% of people who have short-term insomnia go on to have chronic insomnia. And there may be other factors that go into that. For example, you can have another sleep disorder, you can have another comorbidity that can potentiate your symptoms. And unfortunately, it seems that people are less likely to go to the sleep medicine physician for specifically chronic insomnia as compared to, for example, obstructive sleep apnea. A lot of our colleagues, they see a lot of patients, especially in your department, who have been affected by 9/11, and a lot of patients have obstructive sleep apnea and other comorbid conditions, chronic rhinitis, gastroesophageal reflux disorder. And they also have a lot of chronic insomnia. So there's a lot of overlap between symptoms. So we get really good referrals from your department. We thank you for that, to take care of these patients. But that's not always the case from all aspects and from all different places. Often the referrals are just sleep apnea, something like that. But in fact, insomnia is a real big part of what's affecting people around the country. So what is the pathophysiology? That's kind of what we want to get to in order to be able to assess insomnia and properly diagnose it. It could be multifactorial, like I said. There could be comorbid disorders. And the tenets are the 3 Ps that kind of lead to an insomnia condition that becomes chronic. You have predisposing factors, you have precipitating factors, and you have perpetuating factors, something that predisposes it, something that brings it on. A lot of times a tragic or stressful event or a traumatic event, especially if it occurs at night, can be correlated, especially if it's recurrent, can be correlated with developing difficulty with sleep and especially chronic insomnia. And that's a very important factor to consider when taking care of people who are maybe first responders or who are veterans. There are a lot of these episodes that occur when they're protecting us and responding to issues when we're sleeping and they're not. And so this can potentially precipitate insomnia symptoms in patients. And then if there's difficulty with coping with that or comorbidities or lack of good sleep hygiene, you can perpetuate this issue and it becomes a chronic insomnia along with other comorbidities at the same time. And then there are some psychological perspectives that we need to consider. If you're always so hyper-focused on the symptoms, if you're anxious about it, that you have insomnia about that. And if you overly kind of excessively monitor your time to go to bed versus time to wake up, and you're always looking for internal and external cues to reassure you that you are going to fall asleep, right? That's not great. So you don't want to look at the alarm clock, stuff like that. There are lots of things that may be a source of perpetuation for insomnia symptoms. And there have been physiological studies that have been done. We need more studies to be done. I think that the body of research is medium, mild to moderate in terms of how much intensity of research is in the area. We should do more research on insomnia and comorbidities for sure. But the going theories so far have been that there might be a state of hyperarousal, an elevated sympathetic tone that can contribute to a decreased threshold for arousal at night while you're sleeping. And that may make it easier to wake up and more difficult to maintain sleep. And this kind of hyperarousal also makes it more difficult to fall asleep. And studies have been done that looked at increased activity when you're supposed to be sleeping and relaxing and going from a transition from stage wake to stage non-REM sleep, stage N1, 2, etc. Instead, there's an increased activity in the reticular activating system of the brain. What's important about that is the wake system, the activating system of the brain, is more active when it's supposed to be less active. That's the bottom line of that in patients who have insomnia. And in normal patients, when you're awake, there's actually more activity in that region of the brain compared to patients who might have other conditions or disorders. And so that kind of, I would say, maybe opposing paradoxical situation is what's postulated to be a part of the reason why people develop insomnia. So evaluation in the sleep medicine clinic looks at everything holistically. That's what we're supposed to, that's our job. That's my job when you refer to me, is to do things like iStop, PDMP, check the referring clinician notes, check pertinent labs, ensure that there are no red flags or things that go on that may be contributing to a situation where there's insomnia, but also other issues going on. And we use pre-visit questionnaires. Questionnaires are extremely helpful to help guide arriving at a proper diagnosis. They help orient the visit and they help redirect the patient towards why they're there. You are able to focus on what is the issue at hand. If you do the Insomnia Severity Index questionnaire, the patient knows you're there to check their insomnia, and see what's going on with that. If you do some other questionnaire, you're leading them. So questionnaires are very important ways of getting a baseline sense of where things are at, and then as you're following up with the patient. One of the most commonly used questionnaires in sleep medicine, that's the Epworth Sleepiness Scale. And what that allows us to check for, it's been around since 1991, is to check for daytime sleepiness. And paradoxically, a lot of patients with insomnia, they actually don't have very high numbers on their Epworth Sleepiness Scale. In fact, 11 out of 24 or higher is considered positive for excessive daytime sleepiness. You'll ask, the sleep doc still agree? But a lot of patients with insomnia, they don't feel excessively sleepy during the day. Their scores might be 3, 4, or 5 out of 24. They will describe it as, I am tired, but wired. And so they can't nap, and they feel like they're not sleeping at night. They have a perception of a lack of sleep quality at night, and their Epworth Sleepiness Scale may not be particularly elevated. And that may be what you find in a patient with insomnia when they come into the office. And so the next thing in the evaluation everyone should do, especially what's very helpful before they come into the sleep medicine clinic, is critical, is what is their use of hypnotics? What's the history on that? Have they been on zolpidem? Have they been on doxepin? How long? And what's going on? Why are they being referred? Are they refractory to some sort of treatment? And actually, in the evaluation of a patient outside of sleep medicine, it's real helpful to set some expectations. I'm referring you to sleep medicine because we're going to work on weaning you off of this chronic use of Ambien. Let's see how the sleep doctor can help us with that. You have a lot going on with your restless legs, with your sleep apnea. I'm not comfortable that you're taking a benzodiazepine while you have severe sleep apnea. Let's see what sleep medicine can help with that. And so hypnotic drug history is extremely important in any visit, and PDMP and iStop helps with that. And then, of course, the general sleep overall evaluation is extremely important. So in the clinic visit, what should you expect a sleep doctor to look at to evaluate for insomnia? The sleep schedule, the bedtime routine, difficulty with initiating sleep, difficulty with maintaining sleep, and how difficult is it to wake up in the morning or get started for the day, whatever. What are your daytime symptoms? What substances do you use, whether it's to stay awake or to fall asleep? Are they legal or illegal? And any hypnotic history, prescription medication history in general. And then what we look for are evaluation on the physical that may reveal comorbidities that may affect your sleep. Well, if you have sleep apnea, if you have congestive heart failure, chronic CHF, if you lay down and you have paroxysmal nocturnal dyspnea, what's your cardiac exam like? Are there rails? Is there peripheral edema? What's your, just some general basic evaluation is extremely helpful even before they come in for the sleep medicine visit, because that helps to drive the visit in the appropriate direction, because timing is key and diagnosis is key. Testing is also very important. We test patients because a lot of patients with insomnia suffer from comorbidities and sometimes dual diagnoses, right? Because they might have struggles with substance abuse, mood disorder, thought disorder. And so we want to evaluate patients and provide them with an environment that really they're there and they get the most out of their visits. So urine or serum drug screening, even if they're on a chronic medication such as zolpidem, or they're on multiple polypharmaceutical kind of approach to their health, then you might want to consider signing a controlled substance use agreement. And you get some labs, because in sleep medicine, you don't only have insomnia and sleep apnea. You might have restless legs, some sort of sleep-related movement disorder, a non-REM or a REM parasomnia. And so you want to get labs to kind of evaluate and check for what else could be going on. And so you want the CBC, the iron panel B12, a comprehensive, a Chem 22, so that you can get an assessment of their liver enzymes and their GFR, importantly. Why? Because a lot of these medications, they may affect, that may affect how you're prescribing things and how you're titrating things. Certain medications, for example, the newer DORAs, you may have heard of Belsomra, Dayvigo, Qvivic, or the generics, right? Suvorexant, Lemborexant, or Doridorexant, which came out a year and a half ago. FDA approved these medications. They actually get processed heavily by the liver. You might want to check liver enzymes as a baseline and then follow that through occasionally. If the patient comes to sleep medicine and the primary doctor has worked them up and they had some labs and they had a chem panel, that's extraordinarily helpful, because we're able to make decisions and actually the consult goes much better. And then sometimes you might want to get additional imaging to assess for comorbidities that may be associated with sleep disorders. So actigraphy, the nocturnal polysomnogram, the NPSG, MSLT, these are the tests that we rely on in sleep medicine to help evaluate what is the global picture of their health in terms of sleep-wake disorders. Actigraphy is not really covered by insurance, so one way of going around that is to get a good history, a sleep diary, and maybe they have a wearable that they use, which may not be FDA approved, but it may help paint the picture of how they're sleeping, how they're moving around, the Oura Ring, an iWatch, something else that you can download the data, maybe take a look at things and get an idea. It's something to help supplement. It's a form of collateral that helps to supplement the history in order to assess what's going on and actually help determine if they need a sleep study or not. Because patients with primary or chronic insomnia don't need a sleep study, but patients who have comorbidities might need a sleep study. All right, so these are the things to consider when you refer to us so that we can evaluate the patient. Chronic hypnotic use, chronic comorbid sleep disorders. You'd like to wean off a patient with A, B, and C off of a medication, or they have chronic insomnia and they can't access cognitive behavioral therapy. We'll get into that in a second. Or there's not a significant improvement on CBT. The best results usually are behavioral sleep medicine and sleep-wake medicine together. Polypharmacy and therapy together usually provide the best results in order to treat this often very debilitating condition in a lot of patients. So if someone's on regular hypnotic use, this is new from the diagnostic criteria, ICSD-3-TR. If they're on regular hypnotic use and they develop insomnia, that is a thing. So that they have insomnia with regular hypnotic use, that's a referral to sleep medicine. If they have refractory insomnia and they're not responding to the standard of care, standard medications, that's a referral. And again, if they have comorbidities that may be associated with their insomnia, make it difficult to wean off medications, you should send them over to sleep medicine. We'll be very happy to see them and collaborate with you closely to take care of our patients. And when do we refer? So we refer from out of sleep medicine when we're taking care of insomnia patients to another subspecialty if there's comorbid, a neurological or psychiatric condition oftentimes, or even something that has to do with sleep apnea or Cheyne-Stokes respirations or CHF. We might want that underlying comorbidity addressed, right, in order to be able to help the patient. Every time they lay down, they can't breathe. Well, maybe there's something else going on, and that's why they can't sleep. If they have an uncontrolled seizure disorder, if they're concerned about SUDEP or something else or some other kind of condition that may be associated with poor sleep-wake hygiene or sleep-wake disorders, that more research is definitely needed on to elucidate. We want to collaborate with our colleagues to get a better assessment, and that's when we refer. If there's a comorbid thought disorder or mood disorder, we definitely want them to be seen by psychiatry because they might not respond to hypnotics, and that's not really the underlying cause of their insomnia symptoms. All right, so now we got to understand what are the associated risks of untreated chronic insomnia. Well, the obvious one is, first of all, when it comes to assessing any sleep-wake disorder, it's really important to know whatever your perception is of your sleep as the patient. I came in and I feel like I can't sleep, etc. How is that impacting your daytime function? That's extraordinarily important. That's probably the most important thing. Is it impacting your daytime function? Do you feel really bad when you wake up? Do you feel like you can't get through the day? Again, are you tired but wired? And you can't, it's difficult to coordinate and orient yourself in the world. Your stage wake is abnormal as a result of your stage NREM or REM. And so daytime impairment is extraordinarily important to assess, and that's very important even before they are seen in sleep medicine. So what is their cognitive status? What's their mood? How do they perform? Is there any history of accidents? Are we concerned about safety of the patient or safety of others? That's a red flag in any profession. And so that's what we want to assess for, as well as psychological issues, as well as the timing of things. You want to consider, in terms of psychological issues and timing, how did this happen? How did the patient develop insomnia? Were they first really anxious and they had anxiety and something that's been going on and they had some sort of anxiousness and then they developed insomnia? Or the other way, are they in a depressed mood or a depressed state? They're not in with psychiatry. They don't have a diagnosis of major depressive disorder. They're feeling sad. they're feeling down, and then over time, now they're starting to have difficulty either initiating or maintaining sleep. And so the comorbidities really come into play here because a lot of patients with these issues, they're at higher risk for substance use disorder and they're higher risk for suicidality. And that's, sometimes it takes a little while to get in to see some other person to evaluate them, a specialist. So it's always a good opportunity to assess for these things. It takes a couple of minutes if it's possible before you can coordinate. Maybe they need a psych referral as well. Insomnia severity also matters. It correlates with poor quality of life. It correlates with decreased workplace productivity, and there's higher outpatient and emergency department and inpatient utilization of health services. So perception of your sleep issues can play into how severe you think your insomnia is, which will increase your stress, and it might perpetuate the problem. And that's where cognitive behavioral therapy comes in, helps to de-perpetuate the problem. So this Insomnia Severity Index questionnaire is a very helpful questionnaire that helps us to have an understanding of the severity of their insomnia, because that's really important in being able to determine how impactful it is on their quality of life. We do this questionnaire sometimes to kind of get assessment of patients depending on what they're there for, along with the Epworth Sleepiness Scale. The stop bang we typically don't do in sleep medicine for sleep apnea. That's typically done by people prior to referring to us in sleep medicine. So there's a lot of overlap between psychiatry and sleep-wake medicine. I believe the founding father of sleep medicine was a psychiatrist, Dr. Dement, if I'm not mistaken, the late Dr. Dement. And so there's a strong overlap between psychiatric conditions, and this is a very interesting topic. There's so much there to unpack, but really the inability to orient yourself properly and to deal with stress. And then having disorientation neurologically, that can definitely be correlated with a chronic insomnia disorder. And if that's going on, there's probably an increased risk for a mood disorder or a thought disorder. Some things that we see with insomnia is that patients with insomnia symptoms is patients who have major depression. They could wake up a lot earlier than they would like to, and they have what's known as increased wake after sleep onset. And then they might have decreased slow wave sleep. That's the form of sleep that's the non-REM stage 3, which is a very restful, stable form of sleep. That's very important. And they also might have a little bit more REM density. As opposed to patients with schizophrenia, they can have also decreased slow wave sleep on the NPSG. So we want to be careful when we approach treating insomnia, because in some patients, restricting their sleep may exacerbate their other comorbidities. So for example, a patient with mood disorder, someone who's at high risk for mania or hypomania, or has had that before, you might not want to start with sleep restriction. That's not something that a psychologist would be comfortable doing, restricting the sleep of somebody who's at increased risk for having a manic break or episode as a result of decreased sleep. The same thing can be said about patients who might have uncontrolled epilepsy or seizure disorder of some sort. Then they're at higher risk for exacerbation of those issues if their sleep is significantly restricted. So you want to be careful about the approach. And that's a good reason to refer to sleep medicine, because we can make that decision about when should a patient be treated with A, B, or C if they have a lot of other things going on. And there are a lot of patients who have those complex kind of presentations, tens and tens of thousands in New York City. Many patients, many people who have been through traumatic events, they have these kind of overlapping issues. So it's always a good opportunity to send them over. There's also a correlation, not just psychologically with psychological issues and insomnia, but physiological issues and insomnia, because this is proposed, let's say, because of this increased state of hyperarousal, reduced sleep duration. The literature is showing over the past 10 to 15 years that those patients also have increased rates of atherogenesis, increased pro-inflammatory states in their body, which is strongly correlated with coronary artery disease and atherogenesis. And so it's postulated that these kind of increased states with increased sympathetic tone can definitely drive pathology, and suddenly the calcium score is 1,000. Suddenly, you know, the patient's having resistant hypertension, et cetera. So you have a lot of kind of physicians and physician scientists researching this and demonstrating that, at least statistically, there's a strong correlation between cardiovascular disease and severe sleep disorders, particularly disorders of sleep, maintaining sleep and initiating sleep. There's a bunch of studies that have looked at this over the years and just kind of listed them out, and they all kind of are pointing towards, although there's a lot of confounding factors, again, the same confounding factors that it's probably a good idea for us to see the patient in sleep medicine to determine what's the best direction for treatment for the patient and how can the patient take back control of their sleep. These are the same confounding factors that are in a lot of these cross-sectional studies that have been done that looked at the correlation between insomnia and cardiovascular disorders, so systemic hypertension specifically, and heart disease. So this is just the continuation of the list. So that's kind of where we're at with that. I want to talk about treating insomnia next. And are there any questions at this point in time for me? My feelings are not hurt. I shall continue. So the main tenet of treating insomnia is actually, you know, a lot of people say that you want to, refer to cognitive behavioral therapy for insomnia, behavioral therapy all the time, CBT. But, you know, a lot of patients can benefit from pharmacotherapy, and we'll get into that in a second. Some patients do require longer-term pharmacotherapy for their chronic state of hyperarousal. It is just the reality. But you want to see, most people will benefit from behavioral sleep medicine first, or in conjunction with pharmacotherapy. It's just unfortunately not always available. There's probably 30 people who are certified in CBT in like the tri-state area. So not sure why, but that's just the reality. But it is considered by the American Academy of Sleep Medicine to be first-line therapy because it's professionally guided and it helps to address the thoughts and behaviors, literally the 3 Ps that have led to chronic insomnia. It addresses that. That's kind of the source. You want treatment that addresses the source. That's kind of the best treatment. If that's not available, digital CBTI exists. And there are different ways of monitoring that. Not many are FDA cleared, but they are available. And there are sleep diaries that you can do interactively online. And this helps to improve access to general cognitive behavioral therapy, or at least buys time until you're able to see the therapist. You do the digital cognitive behavioral therapy. There are apps that help with that. One app in particular, which according to the VA should be done in conjunction with traditional cognitive behavioral therapy, is their Coach CBTI Coach app. It's free. Whether you're a veteran or not, you can download this app and you can start using it to help kind of move forward with your insomnia behavioral therapy. If you're the right candidate for all the types of CBT, then you can recommend this type of thing to download this app from the VA for cognitive behavioral therapy called CBTI Coach. But not everyone should restrict their sleep or try to restrict their sleep artificially. And then there's a form of brief behavioral therapy, which is only a few sessions of CBTI, basically half the sessions. It goes up to 8 sessions. And it uses fewer resources, but some studies are beginning to indicate that it may be still effective in helping to treat the insomnia in conjunction with pharmacotherapy. And so what it does, what's the benefit of seeing a professional? It's not sleep hygiene. That's kind of what you can talk about to patients at any visit. It's a multimodal form of therapy that looks at techniques to help you relax, psychological techniques to help you reorient yourself in the space of sleep. That's what it is. There are various techniques which use different forms of serial muscle relaxation, biofeedback, things like that help to reorient you into space for sleep so that you're not disoriented and stressed and you're not able to fall asleep. It helps diminish the arousals at night. And that's why it's effective, because it's a multi-component type of treatment. Those other things that I mentioned a couple times, sleep restriction therapy, or even sleep hygiene, that's not really a therapy. And a lot of those other ones are single component. You want something that's multi-component and that a professional can follow and cater to the patient based on potential comorbidities that they might have. So that's the benefit of cognitive behavioral therapy with a professional. Is it's kind of like having a person to help adjust the multi-component therapy as you go along and follow that with sleep diaries. And that's considered a strong recommendation according to the American Academy of Sleep Medicine as of yesterday still. There are 5 main classes of medications that we deal with in sleep medicine that help treat sleep. These classes of medications, all of them do the same thing. They make you sleepy, but they work in slightly different ways. So these classes of medications can be thought of, maybe the pathway that I need to address for this patient is the one that has to do with histamine. Maybe the pathway is the one that has to do with GABA, whatever, melatonin receptors. So that's how you kind of approach benzodiazepines, non-benzodiazepine receptor agonists, melatonin receptor agonists. There's the one that we use for insomnia specifically, the dual orexin receptor antagonist, and the histamine 1 receptor antagonist. These are the medications that are used primarily to treat insomnia, but they're not the only thing. In addition to these, quote, FDA-approved medications, the vast majority of sleep medicine physicians, they prescribe off-label medications because they're quite effective if you prescribe them appropriately. The off-label medications usually are in the category of either anti-seizure drugs or anti-epileptics, like the gabapentinoids, or medications that at higher doses treat conditions, psychological conditions, psychiatric conditions. So at lower doses, the vast majority of these, trazodone, mirtazapine, amitriptyline, and even quetiapine, at lower doses, these medications act back on the histamine receptors, just like doxepin, which itself is a tricyclic antidepressant at higher doses that treats depression and mood disorder. So at lower doses, they all act kind of on the histamine pathway at the central nervous system. And that's what makes them effective for inducing and maintaining sleep. But at higher doses, these very commonly used off-label medications are, they treat mood disorder. And so people think, I'm going to start a low dose of trazodone for you because you also have major depressive disorder and it'll help treat your depression and your insomnia. I don't agree with that, because I think that if you're going to prescribe trazodone at a low dose, you're just going to be treating the insomnia. If you want to be effective as a physician, you have to prescribe effective and appropriate medications. Otherwise, you're either under-treating or you're over-treating, and now you're going in the realm of polypharmacy. So you have to know what is appropriate, and you have to know what you don't know so that you can refer to sleep medicine so that we can help determine what is the most appropriate therapy. So again, there are lots of medications used off-label, but at lower doses, they're essentially like low-dose doxepin. And the other point is the gabapentinoids. Well, really just gabapentin. These are medications that are, gabapentin is used to treat something called restless leg syndrome. I'm sure you all know of it. So really with gabapentin, although of course it makes you sleepy, it's the treating of the comorbidity that then helps you to fall asleep with whatever issues, with sleep you might still have. But you're treating the RLS, you're treating the periodic limb movement disorder potentially, or something else that is disturbing your sleep quality, whether it has to do with neuropathic, disorder or whatever. And that's how the gabapentin becomes effective. It is postulated to help consolidate sleep a little more, and it may help treat patients, I believe, with what's known as frequent alpha intrusion, a sign of poor sleep quality on the NPSG on the sleep study. But really, for your purposes, when it comes to these medications, especially the antidepressants at lower doses, they're antihistamine in function and the central nervous system, unlike the over-the-counter antihistamines, which are systemic. And by the way, they cross the blood-brain barrier and cause you to become drowsy. So that's not the appropriate way to treat something. You have to do the right mechanism of action. So let's get into these medications. So the guidelines at a glance basically look at these medications in terms of benefits versus harms. And as of 2024, this remains to be the same article that's up on the website for the AASM. They only focus on the on-label medications. This is what the research body of research is strongest for. And even though that's what we have the most literature to support, it's still considered a weak recommendation compared to cognitive behavioral therapy for chronic insomnia, specifically. So something like Lunesta or Zopiclone versus Ramelteon, Temazepam, Triazolam. So the benzodiazepines and the non-benzodiazepine receptor medications, they do tend to be the most effective for inducing and maintaining sleep for the vast majority of patients, but they do have or are considered to have higher risk for side effects. And if you're using them for more than a few weeks, I'm not going to give the exact range here, but every patient's different. Usually in the ASM, 4 to 8 weeks is kind of where the thresholds are. You might develop dependency in terms of initiating or maintaining sleep with the medication. So try to shy away from relying on these chronically. They're more of like a bridge to help with behavioral sleep therapy, in my opinion. And so Ramelteon tends to have, out of all of these, a perception of not much improvement in sleep quality and somewhat of a reduction of sleep onset latency by 9 minutes. But you have a benzodiazepine on the right, like Triazolam, and also, according to the ASM, it also reduces, and this is for initiation insomnia, by 9 minutes. So you could see the benzodiazepine and the melatonin receptor agonist, they have the same reduction in sleep onset latency. Now, we can postulate why there's a perception of a better sleep quality with the Triazolam. It may have to do with its anxiolytic properties. But you could see here that these medications are not, one is not specifically always better than the other. I also try to shy away from Triazolam. As you can see here, benefits equals harms. Again, for initiation insomnia, you have the Z drugs like Lunesta, and then you have Zaloplan and Zolpidem, Sonata and Ambien. Also, the most improvement in quality tends to be with the Zolpidem, we see moderate improvement in quality, and the Lunesta, moderate to large improvement in quality. But you have to weigh the benefits versus the harms. And so the black box warning that's on the medication, especially for the Z drugs since April 2019, it says that if you have a history of sleepwalking, you must never take these because it may exacerbate the symptoms and it can be potentially very dangerous. Maintenance insomnia, you could treat with Doxepin or Lunesta. And actually, Doxepin looks pretty effective, and it's considered to be lower risk of harm than Lunesta, for example, but patients may also need their Lunesta for initiation of sleep. So you have to make that determination, which medication for which patient. Now, one is not necessarily, we need more head-to-head comparison, which we don't have for these medications to be able to say one way or the other. So there's something, you probably know this very well, the American College of Geriatrics, they have the Beers criteria. And the Z drugs and the benzodiazepines are listed on that criteria as they may exacerbate side effects in older adults. And so for that reason, they do consider medication like low-dose Doxepin to have a little bit of a better safety profile for that specific indication of sleep, of maintaining sleep, but it may not be the right medication. On this list, actually, even though this is the most up-to-date list, the ASM still does not list the newer DORAs, which are Dayvigo or Quviviq, which have been around already for 2 to 6 years. The other thing I want to mention is you can find this information in up-to-date, but the other thing that's very important to do is to understand what are the guidelines for controlled substance prescribing and what are the schedules of different controlled substances. So we deal with controlled substances a lot in sleep medicine, and you can see that the medications that are considered hypnotics and or anxiolytics are scheduled for controlled substances, and they're in the same category as tramadol, and something like fentanyl is a Schedule II narcotic. And so that's an important piece of information to have on hand when you're doing iStop or PDMP. So the approach to treatment, is kind of algorithmic, and you have to have a system in place. You have to determine, what is the predominant issue of sleep, whether they have the patients, isolated sleep maintenance, isolated sleep insomnia, onset insomnia, or sleep maintenance, or mixed insomnia. And then you go down to determine what is the best pharmacological agents for prescribing for that patient if they're not able to get in to do cognitive behavioral therapy, or they might need a combination of both therapy and pharmacotherapy. And so that's kind of how you approach that. But some medications have a longer onset of action and half-life than others, and that's how you determine which medication is the right one potentially to prescribe. There are risks with hypnotics that you have to take into consideration with insomnia: CNS depressant effects, psychological. Sometimes they induce parasomnia, specifically somnambulism or sleepwalking. And all of the approved meds do carry a warning about a caution about suicidality in patients with depression. I think out of the medications listed here, actually, I should include gabapentin as a CNS depressant, but it's not a medication that's FDA approved for insomnia specifically. And then there are some topics of importance that I think are important to consider when you talk about insomnia that we don't have time to get into today, but I'll mention them. In pregnant women and women with menopause who have already similar statistical risk to sleep apnea as men, in childhood insomnia, in patients with neurodevelopmental disorders, in older adults, and in patients who are hospitalized. There are different settings and to consider when it comes to how to approach sleep-wake disorders. And I think those are important topics to say out loud and to mention. And lastly, I'll just say that, there's not too many wearables that we can rely on, but that is a topic that it's definitely going to become more commonly discussed as time goes on, and it helps supplement the history. Like I said earlier, about 30 minutes back, and pharmacogenomics is going to be a bigger topic as well. And due to the paucity, the lack of availability of therapists who can dedicate 8 sessions over the course of 2 months for cognitive behavioral therapy for chronic insomnia, AI-guided psychotherapy may indeed become a thing. We have lots of topics on AI and sleep medicine this year in sleep. In Texas, we're going to probably have at least 2 presentations on AI in June. So this is going to be a big topic. It's infiltrating every industry very quickly. I appreciate you listening. Thank you.